Welcome everyone to my presentation on dental prevention procedures in childhood and children with special needs. I would like to quickly introduce myself. I'm Dalma Tábi, and currently I'm working at the Department of Community Dentistry as a clinical dentist, and I envision as a PhD student that children with special needs have at least the same oral hygiene indices as their healthy peers, and my mission is to provide them a specialized dental prevention program to improve their oral health indices and their cooperation during the treatments. You can see here my ongoing projects listed. The first one is assessing the effectiveness of dental prevention programs among children through a systematic review and a meta-analysis. And the second one that we are conducting a pilot study for an RCT with a school-based prevention program for special needs children. Let's summarize the background of my first topic. As we all know, bad oral hygiene is a major public health issue, and shockingly, it affects more than 486 million children worldwide. And oral health education could be one of the solutions to this program, but there are no guidelines or there are no one gold standard protocol for this education. So the aim of this meta-analysis is to find out if these programs are effective at all and what is the most effective methods. So our clinical question is determining the effectiveness of these school-based prevention programs. So we included studies where they used children as a population between the age 5 and 21, so from preschool to high school. And the intervention was any type of school-based oral health education. They had a control group who did not receive this oral hygiene education during the follow-up period, and they measured their oral health indices as their outcome, and we choose the DMFT values as our primary outcome because most of the study recorded this data. We are hypothesizing that children receiving this school-based oral health education will have better oral health indices after it. To gather some comprehensive data, we conducted a systematic search, including 3 of the databases. We created search key, especially from every database, but all in all, we used 4 terms for the population and the intervention as well. After it, we had 29 eligible articles to include in the meta-analysis. We have forest plots for every outcomes, but I would like to highlight 3 of them. The first one is our primary outcome. You can see here the changes in the DMFT indices between the follow-up period, between the follow-up time points and the baseline. And you can see here that there was only a 0.06 mean difference between the intervention and the control group, and we can say that this is statistically not significant nor clinically because the DMFT can be measured from 0 to 28 because it refers the number of your teeth which are decayed, missing or filled. And because of the high heterogeneity, we made subgroups based on the provider of the education, but we could not find difference between the teacher-led and the healthcare worker-led groups. In our second figure, you can see the oral hygiene index simplified, the differences between the baseline and the follow-up period, and in these terms, we could find a significant difference between the control group and the intervention group, and there was another difference between the teacher and the healthcare worker-led groups because they were more efficient than when they used other methods, like they played a video in these terms for the children, and it was not as effective as when they used live speech for teaching them. In the 5th figure, we illustrated the oral hygiene index simplified values during the time points. So at baseline, you can see that this value was quite high, but in the intervention group after after the education, there was a gait reduction, but after 6 months, the index increased again, while in the control group has almost the same line. And this follows a typical learning curve, and our conclusion is that we have to redesign these studies and revise these programs during their childhood. In this way, maintaining a good oral hygiene will become a habit for these children, and they won't forget as fast as in these cases. So we have some limitations in this study because of the high heterogeneity, and it was really difficult to compare these interventions. And for our primary outcome, we had a short follow-up period. But in the terms of the strengths, we used just RCTs, and we included different educators and various oral hygiene indices. So we can say that these school-based oral hygiene educations are effective, but the efficiency depends on the provider of the education or the chosen method. And for the implication for research, we can say that we should standardize these indices we are recording or have a longer follow-up period. Now I'm between the version 1 and version 2 of my manuscript, and we are just waiting for the statisticians for some supplementary material, but I would like to submit my paper in July. And as I mentioned, we had a pilot study for an RCT because approximately 7,000 children in Hungary under the age of 19 has some form of movement deficiency in Hungary, and there are no prevention programs for them, and there are no education for the dentist how to treat them properly, and that can be a reason that their DMFT indices are 2 times higher than their healthy peers. So that's why we made an intervention with a specialized dental prevention program, and we have a collaboration with the András Pető Institute, so we included their children. In the pilot study, we did not have a control group because the low number of the children, but in the RCT, we are planning to have it. And we measured their oral hygiene indices and their cooperation during the treatments. We are hypothesizing that an 8-week prevention program results in better oral hygiene in these children. We are excluded the children who were unable to cooperate during the program due to their intellectual disability. And here I tried to show you the allocation of the groups because it's hard to understand. So we are going to have 2 groups parallel, one control group and one for the intervention group. And to maintain the ethical sides of this intervention, every group will start as a control. Here you can see that they are the control, and then they will receive the education after they left the trial, and the new group will come. During the intervention, there are 2 parts. In the first part, there is this 8-week program I mentioned, when they are receiving this education for 8 weeks, 1 hour weekly. And after the 8th week, there is an observation time when they are maintaining their routine, oral hygiene routine, and we are measuring or recording their data in every 8th week. So I hope it's clear. It's a circular-like program. We are measuring their oral health indices, and we would like to gather some data as secondary outcomes through a questionnaire. I started this work in 2021 with my thesis work, and now we have just finished the pilot study and analyzing our data and doing the sample size calculation and the protocol drafting. As a summary, I have 2 ongoing projects, but I would like to finish them both during the summer, and we are thinking about a 3rd project. I would like to thank you for your attention with a quote from Teddy Altman from Grey's Anatomy: "You have to go back to the beginning to understand the end." Thank you.
Okay, so thank you for the presentation. My question is in connection with your second project. How did you choose the 8 weeks for the program time?
Thank you for your question. We choose this 8-week period because we tried to summarize the important parts of the dentistry. So there are these important topics like the part of the oral cavity, the oral diseases. They have 1 lesson for toothbrushing, 2 lessons for get familiar with the dental office when they can try out the instruments, they can be a dentist for an hour. And we included 2 sessions for revision and 1 session for the introduction part. And in this way, we get this 8-week program.
Thank you for your presentation. I just have one question regarding the first project, I think. You mentioned that the children with specific needs, but I don't really understand the term, like what does it mean, like what are the children with the specific needs? So yeah, thank you.
Thank you for your question. We call patient with special needs in dentistry every patient who needs some more during the treatment. In this way, we are investigating the children who has some movement deficiency or some lack of mental ability, but everyone, for example, who has panic attack during the treatments or who has like movement disabilities, who have Down syndrome, so everyone who needs some more during the treatment and not an average patient, if we can say. Thank you for your question.
Okay. Thank you for the presentation. I would like to ask you about the scores you're using. So are these validated somehow? And if yes, was the validation done using such a group, or maybe, or what do you think? Is it still valid for this special group as well?
Thank you for your question. Yes, these values are validated from, I don't know, the beginning of the 19th century, I think. So they have articles describing these methods. And for example, the DMFT is defined by the WHO. So they have a definition of how to take it. They have a scoring system for it. So every values or every indices in this project are standardized.